Hello there, my name is Zoya Khan. I am a PGY2 at the Internal Medicine Residency Program at Lakeland Regional Health, and today we have a very interesting case regarding anion gap acidosis that was masquerading as a seemingly simple starvation ketoacidosis. Here we have a 76-year-old female with a history of hypertension, hyperlipidemia, and type 2 diabetes who was taking metformin at home, who presented with 5 days of nausea, vomiting, and diarrhea. She denied any recent antibiotic use, travel, or sick contacts. On arrival, she was noted to be hypotensive and hypovolemic on physical exam. Labs were significant for a BUN of 78, a creatinine of 7.08, as well as a bicarb of 5, an anion gap of 51, and a lactic acid of 24. An arterial blood gas analysis demonstrated a pH of 6.8, a PCO2 of 26, PO2 of 80, and a bicarb of 11.9, which confirmed that she had a severe anion gap metabolic acidosis with concurrent respiratory acidosis. Given her GI losses and hypovolemia, the patient was initially diagnosed with a prerenal acute kidney injury with concern for possible progression to ischemic acute tubular necrosis. The presence of ketosis and the elevated anion gap led to a working diagnosis of starvation ketoacidosis versus diabetic ketoacidosis, and she was started on an insulin drip and an IV bicarb infusion in dextrose. However, her lactic acidosis persisted, and despite fluid administration and resolution of her hypotension, her lactic acidosis was out of proportion to typical starvation states. That raised concern for an additional etiology. Her profound acute kidney injury impaired metformin clearance, which ultimately unmasked a metformin-associated lactic acidosis, which is a rare type B lactic acidosis that is not typically associated with tissue hypoxia. Metformin has become the initial drug of choice for diabetic management. It is a biguanide, and it inhibits mitochondrial respiration in the liver, which can increase plasma lactate. However, typically, a secondary insult, such as acute kidney injury, is necessary to disrupt this lactate clearance, which can further cause metformin-associated lactic acidosis. This is pretty rare in that it's typically seen in less than 10 cases per 100,000 patients, and mortality can reach up to 50%. In our case, the patient presented with GI losses and hypovolemia, which caused an acute kidney injury with concern for progression to acute tubular necrosis. However, because her profound lactic acidosis was not treated despite treating the hypovolemia with IV fluids and treating with an insulin drip for potential diabetic ketoacidosis, this raises suspicion for an alternate etiology, ultimately unmasking the presence of a type B lactic acidosis caused by metformin. The patient underwent hemodialysis, and the lactic acidosis, as well as the anion gap, resolved. The ultimate takeaways from this case are that it is important to review patients' chronic medications and to consider these as a causative factor. It is important to consider metformin-associated lactic acidosis in any patient on metformin with severe lactic acidosis and no overt signs of tissue hypoxia, especially in the setting of acute kidney injury. And lastly, lactate levels greater than 15 and persistent acidosis despite fluid resuscitation should prompt early nephrology consultation for possible hemodialysis and looking for an alternative etiology for lactic acidosis. Thank you very much.